I did my houseman in University Hospital, and then when I was in Sramban Hospital, I somehow was interested, and radiology seemed quite interesting, something different. And they had different modalities and how we looked at images and make a diagnosis. So I think that really fascinated me. And so I went on to choose radiology first. So I did my master's from 1994 to 1998 at University Malaya. And then when I was there, we saw many women actually coming to the breast clinic and coming with, cancers. And somehow you see, not like in the Western world, on this part of the world, you also see the breast cancer in the younger women. So I felt that, I felt that I think I should help and go about to help women. So that's when I finished my master's in radiology, I went on to do my subspecialty in breast imaging. So I was fortunate, I was one of the first few to do breast imaging. In fact, I was one of the first. And then I was sent to Australia, where I did my training under a very renowned breast radiologist as well, Dr. Mary Ricard, in Breast Screen, New South Wales. And during the 1 year with her, we actually read a lot of mammograms. And when we saw, we could actually, during screening, pick up very small lesions. Lesions as small as 2 cm, 3 cm we picked up. And on a follow-up, when we were looking at patients that came for follow-up screening, some of them were coming actually for 20 years now. And when you look at them, they are actually very well. So there's actually something that we can really do. So that's why I always encourage and I always tell all women, please go for screening. Sometimes when we do screening, we can actually detect something even before you as the patient can feel it, or even before the doctor can feel it. So that actually was what that made me go into breast imaging.
Right. And in this, we always hear, doctor, about mammograms. And, it's almost become synonymous for, like, when we talk about breast cancer screening, we always only talk about mammograms. But that's really not the only kind of weapon of the breast radiologist, right? The breast imaging radiologist, you've got so many other things that you use as well, isn't it, doctor?
Yes, but mammogram is actually the gold standard. We have other imaging modalities like ultrasound. Ultrasound is an adjunct to mammogram. Now, with the development in technology, we have the tomosynthesis, which is very helpful, and it can pick up more lesions. And we also have the contrast enhanced mammogram, which again, we can actually pick up and look at lesions and tell the extent of the lesions as well. So these are actually advances in technology. I think a number of hospitals has tomograms, but contrast enhanced is still relatively new. We in HKL, we were the first to get the contrast enhanced mammogram. But now I think there are 2 other hospitals having it as well, in Klang and in Sabah, in Tawau.
Right, right. And this is in the Ministry of Health, doctor?
Ministry of Health.
Right. Doctor, but also the breast radiologist doesn't only do the imaging, right? You also do a lot of active intervention in terms of, taking the actual biopsies when needed.
Yes, yes, we are responsible. What I developed in HKL, usually the patients will come to us when we do a mammogram, and if I were to notice or see something, I will do whatever that's necessary at the same time. So if I need to do an ultrasound, I will proceed with ultrasound. And if there is something that is worrying, I will straight away proceed with the biopsy. So at one stage, as a one-stop center, I will perform everything. So it is very convenient both to the patient as well as to the attending doctor.
Right, absolutely, doctor. That's amazing, because the reason I was asking you is, not many people realize that there's actually a subspecialty called breast radiology, and what is it that breast radiologists do? Thank you so much for sharing with us a little bit about that, doctor. This evening, doctor, you're going to speak to us about challenges and impact of COVID-19 on breast cancer screening. Overall, has it been bad in terms of what's the impact really of COVID onto breast cancer screening?
Okay, yes, it has not been too good. Maybe I will share my slides and then we will discuss on that.
Absolutely, doctor. Please go ahead.
Okay. So today I have chosen, I was given this topic, challenges and impact of COVID-19 on breast screening and management of breast cancer. And as rightly said by Dr. Murali, breast cancer was chosen being Pink October. And we all know Pink October is dedicated Breast Cancer Awareness Month. As an introduction, we all know the coronavirus was first identified in Wuhan city on the 12th of December, 2019. So since it was discovered in 2019, the disease was named COVID-19 by the World Health Organization. Later, on the 12th of March in 2020, WHO classified this as a pandemic. In Malaysia, the first case was detected on the 25th of January 2020, where the 3 Chinese nationals were in contact with a Singaporean that was infected with COVID-19. And the first Malaysian that was confirmed with COVID was discovered on the 4th of February 2020. So as we know, this was a pandemic. It was highly contagious. It was going all around the world. Many countries were affected. So were we in Malaysia. So a movement control order, or a MCO, was announced by our Prime Minister on the 18th of March 2020. So there were SOPs drawn up, there was restriction on traveling, and only 1 person per family was allowed to go out to buy essential items. And at this point of time, the health system was fully operational. However, we had limitations and challenges. Despite all that, our healthcare, we still tried to do our best for all our patients. So what were the challenges faced by the healthcare during the COVID-19 pandemic? Okay, and I have actually focused this more towards breast cancer management and screening. So if we look at this from 3 perspectives: from the patient's point of view, from the healthcare worker's perspective, and we looked at the healthcare system, the Ministry of Health as a whole. Okay, as we are all aware, breast cancer is the leading cause of death among women around the globe, including Malaysia. So We actually have services where we divide them into screening services and diagnostic services. So just to explain to those who are with us today, what we mean by screening is when a well person that walks into our clinic to get the breast examination done. So these tests are done to identify any lesions in the breast. And I must say, there are many studies done around the world, and it has been proven that screening is an effective prevention mechanism that can reduce cancer mortality rates. And there is evidence that there is a 20% reduction in mortality at all ages. Okay. And there's another very interesting point that I would like to highlight. With screening, we can actually detect the lesions 2 years before they can be felt, whether it will be felt by the patient or be felt by the doctor. So this is where the mammogram comes in, and mammogram forms the gold standard because we are able to pick up the microcalcifications, which are actually all the precancerous lesions. Okay. And of course, for screening, when we talk about mammograms, in the latest guidelines as well, that has been just released in 29, just released it a year ago, we say screening mammogram, we will start from the age of 50. However, patients who are 40 to 49, they will not be denied. So if a 40-year-old patient comes to us and needs a mammogram, it can be done. For the younger patients, sorry, we actually will do an ultrasound. Okay. And again, the patients, once they are seen by the doctors, there'll be a few questions that will be asked, and then we will actually categorize the patient as either they are low risk, moderate risk, or high risk. So the patients who are on the low and moderate risk, you will get your mammograms every 2 years. So once in 2 years. Whereas for those who are on the high risk, they will get yearly mammograms. And who are these people who come in the high risk? They are actually people who have had cancer of the breast on one side, or somebody who has got a first-degree relative, that is the mother or a sister who has had breast cancer, a person who has had during the breast examination that shows atypical cells, or those who have had childhood chest irradiation for previously for any other chest malignancies. So this high-risk group, or those who have got genetic reasons, so this high-risk group, once they are seen by our doctors, and if they need, then mammograms, yearly mammograms will be done. Okay, so that's for screening. And I encourage all women, please go for screening. When it comes to diagnostic, what we mean is patients who are having a symptoms when they walk into our clinic, these are called diagnostic services. It may be either a lump, there might be a nipple discharge, they might have even skin changes or skin thickening. Whatever symptoms, whenever the patient walks in with a symptom, then it's called diagnostic services. Okay, now let's look, what were the challenges that we faced at the hospitals? Especially during the initial MCO when we started in March, and if you looked at our statistics, in 2019, comparing 2019, 2020 and 2021, the number of screening and diagnostic cases showed a tremendous reduction, especially the screening. It came down almost 60%. Missed appointments, patients were scared to come. So many patients were missing appointments, and there was an increase almost about 40%. Then there was also a delay in appointments at clinics and radiology department, because sometimes some of the radiology clinics as well as the radiology departments and clinics, we were working with minimum staff. Some staff had to be diverted to other areas to help out in the COVID wards. Okay. And screening mammogram and the survivors, where we do the yearly mammogram screening, they were paused temporarily. So these were all the challenges that we were facing. So now, looking at the challenge and impact from the patient's perspective. One, the patients themselves were scared. They had fear of coming to the hospital, and many of them didn't want to come. Next, there was a lack to access to health care. So some examinations and procedures were temporarily closed. Even some healthcare centers, normally they will go to the health clinics or clinic kesihatan. Even there, some of them had to be working at minimum strength, or they had to be closed because they were desperately needed in other areas to help for the COVID as frontliners, in the COVID wards, or any other duties. Some had problems. They said they had difficulty or lack of transportation to hospitals. So even the public transport was running at a minimum. Unemployment, there were a number who had actually lost their jobs, and it was very sad. Due to financial reasons, they were unable to come to continue treatment. And of course, there were a few who said that they were actually quite busy because they were caring for ill family members. So basically, the outcome on patients, in summary, it was delay referrals to the clinics. There was a delay to get mammogram, ultrasound, and biopsy. Normally, we always, when I was in HKL, we always get, if there were any cases that were urgent or suspicious, we will always, within 1 week, the mammogram, ultrasound, biopsy, all will be complete. 1 week, usually less than a week. But here, at this point of time, it went on 2 to 3 weeks. So there was already a delay there. Then, because we also had reduced the screening, there was a decrease in screening. There was an unexpected rise in cancer incidence. And the delayed cancer diagnosis, this led to increase in mortality. And there were more cancer deaths. So basically, this led to poorer outcomes and shortened survival. So that was from the patient's perspective. Now let's look at the healthcare staff's perspective. Now the clinicians actually had a very, very challenging task. The clinicians had to balance now the risk of delaying the cancer treatment or looking at the effects of COVID exposure, risk of COVID exposure, or the adverse outcomes of the COVID-19. But as all clinicians, as all doctors, They actually are still very concerned about their patients, and they navigated this with care while maintaining physical distancing, and even with the limited healthcare resources at the clinics and or at the wards, we still did our best to manage these patients, and all were done and managed by priority. Okay. There was negative psychological impacts, and this was at all categories of staff, doctors, the nurses, the radiographers, multiple levels of stress. Okay. And as I said, there was interruptions in routine job duties and responsibilities. So staff that were working actually in the normal clinics, they were actually now diverted to wards, diverted as frontliners, diverted to other hospitals or other centers. Okay. And like even clinical visits, all these had to be postponed. So sometimes if you see, especially our oncologists, they actually go to other hospitals or other states to give their expert care and management to these patients. All this had to be postponed now. And as again, there was delay in surgery and other treatments. So again, all these were actually multiple impacts that we were facing at the healthcare. So having all these challenges, what did we do about it? Some hospitals, they were selected to manage COVID-19 patients. But there were most other hospitals where we managed not only the COVID-19, but also the non-COVID patients. We tried to manage these cases and patients as well. Hence, it was a challenge because we had to reorganize our clinics. We had to re-alert again, reappoint all our radiology appointments. We had to redirect our staff. So all these were challenges, but we did it step by step and we tried to manage and do the best. During the initial lockdown from March till about June or middle of July last year, 2020, all appointments at radiology and clinics we were closed, except we were managing all the urgent cases and the inpatients. So again, priority was given. Again, our surgical colleagues and our oncology colleagues, surgery, radiotherapy, and chemotherapy, they were again managed by our colleagues by priority. Okay, and staff had to be deployed to other areas, either within the hospital, to other hospitals. And I even had, when I was in HKL, I even had to send some to Sabah. They had to go to other states to help out because other areas were also in desperate need for help. And we had to help each other during these difficult times. Then as the partial MCO came in, we started to manage our cases again, and we started performing again all our appointments and our modalities. And again, we prioritized all the cases. And I can assure you, all cancer patients were given priority. All ill patients were given priority. Okay, and the screening mammogram was also resumed. And as we know, not only the appointments that we had postponed, we had to look at, but also the appointments that had already been given that we had. So we had not only the backlog to look at, as well as the appointments that we were having. We had to screen, we had to prioritize, we had to lengthen our working hours, but somehow we managed and we did our best. And just at a point on talking on mammograms, there are some patients who actually had vaccination. So for those who had post-vaccination, we actually advised them to come 4 to 6 weeks after the vaccination. This was there was a reason to it, because sometimes after the vaccination, there will be temporary swelling in the armpit. So we did not want to misdiagnose and say that's a cancer or something. So post-vaccination, it is a temporary swelling. Within 4 to 6 weeks, it should disappear. Should the swelling persist, then we will proceed and do a biopsy and look at the diet and follow according to the results of the biopsy. We also did something else where we actually collaborated with other hospitals, the university hospitals, the Ministry of Defense hospitals, and the private hospitals. And we need to say, I think everyone worked together, and as we had very good teamwork. And even we from HKL, although because our anesthetists and all were also very busy handling many of the COVID ill cases, category 4, category 5 cases. So some of the OTs, they had to cut down. We actually went to the Ministry of Defense Hospital to do the surgeries there. Our surgeons actually, we went and performed surgeries there. In the same way, just like surgeries, other procedures were also carried out at the various different hospitals, at some of the university hospitals and private hospitals. Another measure that we took, we had this teleconsultation. So many of the patients, they could ring the clinic if they had any issue, anything that they were worried about, or if they needed an opinion. So there was always a healthcare staff to answer their queries. And if there was anything that was worrying, then they will give them a quick appointment at the clinic to see the doctor. And I thought I also would like to share with everyone how we actually managed the workflow for patients that were going to be operated. So patients that our colleagues, the surgeons, had decided needed an operation, these patients were admitted 2 days prior to the surgery, and they were kept in a special ward. So while in the ward, after admission, the PCR test, excuse me, and chest x-rays were done. So our lab colleagues, they were very helpful. They ensured that the results come to the surgeon before they can be posted for op. Chest x-rays that were done were sent to the radiologist and they were reported the same day. So once both these were clear, then the patients will be posted for surgery. And all our surgeons and anesthetic colleagues all used proper PPE. We had taken all the necessary precautions and all SOPs were strictly followed. So as much as it was a challenge, we all sat together, we did our best, we worked as best we could for care of patients. So that is how we managed in HKL and what I would like to share with you all.
Thank you so much, Doctor. That was really very interesting and so informative. We've got quite a few questions, Doctor, but before we kind of kick in, I just had my own kind of question that I wanted to put to you to share with our audience. Now that things have gone kind of slowed down a little
Yes.
in terms of the numbers of COVID-19 cases,
Yes.
well, what is your message for people who kind of have been a little worried to come to the hospital, restart their screening? Any message that you'd like to share to them?
Okay. I think for all who are coming to the hospital, we actually do COVID screening before they come. So we'll just ask a few questions and then we see if they have any symptoms or any temperature. And then we proceed to do the examination. I think now that, I mean, we are walking everywhere. There's so many COVID patients everywhere. So, but whatever it is, the onus is still on us. We take the precautions. But I think coming to hospital should not deter them. They should still come if they need to. And back in the hospitals also, all the necessary precautions are taken. The clinics are all open and appointments are given so that, we can manage them properly and in a timely fashion.
Right. Doctor, I would really help for us if you could also kind of dispel some of the very weird queries that we had. We kind of on social media, we get a lot of weird queries, especially during this time pertaining to breast screening. So I'm going to ask you whether you would be able to take some of the weirder queries that we've got. One of the weird ones is when they use the gel to do ultrasound,
Yes.
can you transmit COVID within the gel from one patient to another in the transponder? That's actually a question that someone's put across.
No, no. Because when we clean and everything after that is disposed. So we take all the necessary precautions. No worries about that.
Lovely. Thank you so much, Doctor. Also, on the same note, when the mammogram machine, the depressor that they use, is it sanitized at every time? Is it safe? Am I going to get COVID if I come and do a mammogram screening?
No. Every time they do, they will clean as well the machine, the plate, the compression plate. So you will not get COVID by that way, this thing.
Right, absolutely, Doctor. How about, so do a lot of people have not come for screening, Doctor, as you yourself were giving us the data earlier on this. So as we reach the tail end of the year, we're coming on to November, December, would you tell people if they haven't they've let go during this past year and a half during COVID, is it the good time to restart and start doing your breast screening and all that again?
Yes, definitely. We have actually tried now to call patients back, and especially those who are on the regular screening and those who are the survivors who are doing their screening as well. So we do have and call them and encourage them to come.
Absolutely, absolutely, Doctor. Doctor, then along this, you, I think, acted very nicely earlier to tell us so much about this temporary inflammatory reaction that you get post-vaccination that causes kind of the lymph nodes to be a little inflamed just after receiving the COVID vaccination. Now,
Correct.
There's some query, Doctor, and this is one of the questions that is put across from us. Is there any specific vaccine in which this doesn't happen, or does it happen for all the vaccines, Doctor?
From what I have read, it can happen to any of the vaccines. So I think most of them, they actually, their function is almost the same. So again, it depends on the patient. Some develop the swelling. For some, there's no swelling. So there's nothing, there's no specific vaccine as such.
Okay,
And
lovely,
not
doctor. So
all
it's a
patients have that swelling as well.
okay. Any idea, doctor, of like a percentage of how many people, one in 10, 2 in 10 who actually get this kind of temporary reaction?
I'm not really too sure about that.
Okay, but which is why we're recommending that people wait 6 weeks, right, doctor?
Yes.
You were saying
yes.
4 to 6 weeks.
This
right,
was
before they
actually
come
the
back in.
people from US who had done the study, and actually the oncologist team in US had done the study, and this was their recommendation. So they felt that after 6 weeks, then it was relatively safe. Should the swelling still be there, then proceed and do a biopsy, look at the results, and from there, then the necessary treatment to be administered. Yes.
Right. Got it, doctor. Doctor, in the sense that, this is an interesting question. One of our viewers is asking, how about when I get the booster dose? Should I then also wait 6 weeks before I go for a breast check?
Well, it's very difficult to say, but should they develop a swelling, then we will suggest hold on first, wait and see.
Right. Absolutely. But doctor, this is really for people who are getting some kind of a lump or that, which is after their vaccination.
Yes,
right?
after
For
the vaccination, yes.
How about for people who say have been they've been feeling a lump, and then now they're a little bit more braver. Now they've got the vaccine. They recently got the vaccine, but the lump has been there long before the vaccine. Should they kind of also be advisable for them to wait, or should they come in right away?
No, I think if they have had a lump already, it must be investigated. We need to know that lymph node, whether it's a lymph node or some other lump, what that lump is. So a biopsy is definitely warranted. It's better to be safe.
Right, absolutely, doctor. Doctor, there's also a very interesting question on, okay, so what is the difference between 2D mammograms and 3D mammograms? And now people, I think this may be a kind of misconception. So what is a 5D mammogram? Is there such a thing, doctor?
We don't have 5D mammograms.
Yeah, I think they're mixing it up with an ultrasound.
You see, what we have mammograms last time, it used to be the 2D mammograms. So where we just compress and we do it in 2 different views, the mediolateral view and the CC view. So, but now what we have is what we call the 3D mammogram. And what this 3D mammogram does, it's actually like what the CT scan. So as it's doing the examination, it is actually looking and taking the images at every slice, different slices of the breast. So we actually look at different every centimeter of the breast. We look at the different slices. Hence, we can pick up more lesions compared to the 2D mammograms. So it is just like CT scan where we do many cuts. So different machines have different angles how they do it, but all the same, the concept is the same.
Right. Absolutely, doctor. Doctor, so there's another question from one of our viewers on, should I be doing mammograms yearly? Is there a higher range of radiation exposure when I do this so frequently?
So like as I had mentioned, we have very clear guidelines. So we will categorize these patients as low risk, moderate risk, and high risk. So only the high risk cases, we advise yearly mammograms. Whereas the low and moderate risk, you do mammograms once in 2 years. And to say about the radiation and the radiation dose, extensive studies have been done in Australia, in the UK as well, where they actually see the dose of the mammogram, even on screening, as minimal, low dose. And it is very safe to be used as a screening tool. So that is why in many of the Western countries, they have population-based screening. We do not have population-based screening in Malaysia, but we have like opportunistic screening, or we tell patients 40 and above, please come get your breast examination done.
Right, absolutely, doctor. There's also a question on this is quite a long question. I see many promotions for mammogram and ultrasound together, but doctor today has been speaking about mammogram for older women and ultrasound for younger women. Should I be doing both of them, or is just one of these tests adequate? There's no age, so I'm just going to. It's a lady asking this question.
That's a good question, and I'm glad she has asked this question so we can explain. So you see, mammograms, they are done for women who are 40 and above. The reason is because in the younger women, the breasts are still dense. So that's why, should there be like microcalcifications, they can be missed in the dense breast. So that's why we do ultrasounds. Now, when we say we do mammograms, sometimes we need to do the complementary ultrasound. So we may see what we call a lesion or a mass, but we would like to determine and to know what this mass is. So when we do ultrasound, we can tell you, oh, this mass is only a cyst. That means it's only a mass with fluid in it. That is safe, don't worry. A cyst is considered safe. Or when we do an ultrasound, we see, oh, this mass is a solid mass. Now we look carefully at the features of this mass. Look at the margins, look at the echogenicity, look if there's any posterior shadowing. So when we look again at all these features, then it will help the radiologist to say, is this a suspicious mass or is this a benign nodule? So if it is a suspicious mass and we can see it well on ultrasound, we will proceed straight away with ultrasound guided biopsy. So each modality, it has its special role. So sometimes with mammogram, we still need to do an ultrasound. Or sometimes certain mammograms, even in patients who are 50 years old, the breast is still dense, then we still would like to do a complementary ultrasound just to check. So if we do the mammogram and ultrasound, then we have better specificity in our examination.
But okay, and sure enough, the next question is exactly what I predicted. How do patients determine the density of their breast, doctor?
Sorry, how do patients?
So there's someone asking how do we determine the density of our breasts?
That one only when we do the mammogram we can see and tell.
Oh, right. So it's something the radiologists will determine, right? Not,
yes.
Nobody will. Yep. So
no,
there's no
it's
measurement.
Only from the mammogram we see, and then we classify the breast density.
Right. But breast density is just like a physical thing, right, doctor? It's like how tall are you? It's got nothing to do with whether you're prone to get cancer or something like that, right?
No, there is also people with dense breasts are more prone to get cancer, so we have to be more careful. So we actually, that's why we also will do ultrasound. We want to make sure that everything is clear.
It's clear, exactly. So, ladies and gentlemen, that's exactly why you get that mix and match kind of variation and why people sometimes put both tests across. So unfortunately, there's no self-measurement for density of breast. So that's something your doctor will actually kind of determine when they're examining you. When the radiologist is actually doing that imaging, they'll kind of like decide that, this is a dense looking tissue, and we need to do something about it. That's right, doctor?
Correct.
Okay, Doctor, you've got a lot of interesting questions today. So there's a question which is on, I have stopped breastfeeding for the past year and a half. I am now 38, and my mom is a breast cancer survivor. Should I already start getting myself checked? Yeah.
Yes. Once they have a first degree relative, then they must get themselves checked, see the specialist, the breast surgeon, and then they will examine, and then they will recommend. So again, we will start with ultrasound, but should we see sometimes that if we could proceed with mammogram, we may start just with one view if we feel there's something worrying there. And in that one view, if it can be helpful, then we will proceed and do the full mammogram. But for some reason, if the breast is very dense and we see that we are not going to get any added information, then we will not do the examination, because we do not want to expose the patient to unnecessary radiation.
Right, absolutely, Doctor. Doctor, this is a question that came up as well, and this is quite an interesting question in that sense. So this person, this viewer says, look, I've been doing self-breast examination very regularly. I do it, in fact, every month, and I am very careful about myself. There's a bit about how their diet is good and all that. Why do I need to do breast screening? I can do my self-breast examinations. Isn't this enough?
No, because sometimes some of the lesions, when they are microcalcifications, you will not be able to feel it on breast self-examination. So that's why we suggest they must do a mammogram. And these microcalcifications are best picked by mammograms. So that is why we still say mammogram is the gold standard.
Right, absolutely, Doctor. And that is an important point, ladies and gentlemen. So this is not to say don't do your breast self-examinations. Rather, it's about complementary. It's plus rather than or. So it's like, do your breast self-examinations, but as Dr. Shantini is saying, you need to come do your regular scheduled screening as well, because you can pick up what your hands cannot.
Correct.
Lovely. Thank you so much, Doctor. Doctor, there's one more question on what is, okay, so this is quite a vague question. I think the person didn't quite finish. What do you mean when you say low risk? You were saying earlier, I think this is alluding to what you were saying earlier, Doctor, about high-risk women, medium-risk women, and low-risk women for frequency of screening. I think that's what this question is about.
That is for the frequency of screening. So when they see their doctor, the doctor will tell them, after asking them a few questions, then they will categorize them as either low risk, moderate risk, or high risk.
Okay, and I'm going to ask a follow-up question, Doctor. Let's say when you have been categorized as low risk, for example, can that situation change? Can you become a high-risk person at some other point? Possible. Right. So it's also something that is changing from time to time.
Yes. Because sometimes you may be a low risk, and then on the following year, say your sister developed breast cancer or your mother developed breast cancer. Now your category will go to high risk category.
Exactly. That's a really important point. Thank you so much for making that, Doctor, because Sometimes I have patients who will say, oh no, the doctor told me 10 years ago I was low risk. So they'll hold on to that 10 years ago statement and travel all the way through. Doctor, this is, I think, a more targeted question. Okay. I am a survivor who had early stage lumpectomy. I'm above 60 years old. I'm a survivor now for more than 15 years. Do you think I should do a mammogram 2 yearly or yearly?
Well, actually, all over the world, they still recommend yearly mammograms, this thing. So I would still advise yearly mammograms, but for some reason, if she has different opinion, best she discusses with her surgeon or the oncologist. Yeah.
Yeah, absolutely. Because please be aware as well, ladies and gentlemen, so because this is an open session, we're not able to look at your own personal history and make that kind of clinical decision. All the kind of recommendations are in a general context for almost everyone in the population. But for a specific note, I think you really need to see your individual physician for them to make a choice as to how your treatment is going to be. Doctor, as we move into the tail end of today's session, there is one question on why can't I do CT scans instead of mammograms to screen for my breast?
No, because CT scan, actually, one, the dose is very high. Number two,
Right.
in mammograms, we are actually sort of pulling the breast, and it is more targeted for a breast examination. CT scans, we can see nodules, but still we have to go back again to do mammogram or to do ultrasound to re-look at the nodule. So CT scans are not meant for breast examinations.
Right, absolutely. And those are important points, ladies and gentlemen, because again, this is a common misconception a lot of people have, that CT scans are a lot easier. You just lie down and then you go into a machine and come out. So there's not much pain in terms of breast compression for the tissue and all that. So a lot of people have this idea that, oh, it's easy, I'll just get it done that way. But what doctor is saying this evening, and this is a point of note, is don't forget that CT scans have a lot more higher radiation exposure, and they're not as specific for breast as well. Thank you so much for kind of clarifying that out very clearly as well, doctor. So as we kind of are coming to the end of this session, and thank you so much again, doctor, for joining us and kind of fielding all these different questions from all our viewers this evening. Could we ask you on some words of wisdom as we wrap up this session on breast cancer screening in peak October?
Yes. Okay, maybe my take-home message to all the women out there, I would suggest for those who are 40 and above, please go see your doctor and get your screening mammograms done. I think it is very helpful. Sometimes, we do not know what we are having, but should we have something and it can be detected early, your life that with the necessary treatment, you can lead actually a very good life. Like what I saw in Australia, people post 20 years after breast cancer, because it has detected in a very early stage, or especially in the precancerous lesion, they are actually very, very well. You will never look at them differently compared to like an ill person. So that is why I really still go ahead and tell women, please go for your yearly mammogram, go for your routine mammograms, and the doctor will advise you whether you need it yearly or 2 yearly. And my next message is, always once you have finished your mammograms, please keep all the films with you very carefully. because this is very, very important for the radiologists when they are reporting. So we always like to compare with the previous mammograms, and we'd like to see in the present ones, should there be any changes, then we will intervene fast. We might have to do a biopsy, or we might have to do something quickly. So again, my second advice, keep all your mammogram images, and every time you come, bring it along with you. And of course, my last message is the breast self-examination. Do it every month. If you see any changes in your breast, or any skin changes, any nipple discharge, anything, go and see your doctor quickly. So these are my message to all the women out there.
Thank you so much, Doctor. So, ladies and gentlemen, as we come to the end of this session, Doctor has very kindly shared with us many insights about all these issues which a lot of people have been facing during breast cancer screening, from the patient's perspective. But wasn't only the patients, the doctors had, the clinicians, the health system had a lot of issues as well, and how we coped with it. And most importantly, the message is, hey, COVID belum habis tapi sudah turun, tapi cancer hari-hari still ada. So if you're not going to use this opportunity of Pink October to kind of get up and come out of your house and go and get screening, I think Dr. Shantini has spent this evening making that case for you. So ladies and gentlemen, please allow me to thank on behalf of all of us this evening again, Dr. Shantini Arasaratnam, consultant breast radiologist, for joining us and speaking in this session of Cancer and I. Thank you so much, Doctor.
Most welcome. Thank you.
And a very good night, ladies and gentlemen. We'll see you pretty soon. Take care.